Welcome, everybody. That's what I'm going to say in terms of a welcome. I'm going to go right into, we've got an amazing lineup this year at the conference, and it starts with our first two speakers. We have Secretary Robert Greene, who is here, and he is going to share with us what's happening and his plans. And last night, we gave 2 awards. Our awardees are represented here. Dr. Stephen Sharfstein received our Royal Riddick Lifetime Achievement Award. There is Dr. Sharfstein. And Secretary Greene and Commissioner Hill in Corrections accepted our first ever, well, it's not our first ever Community Partner Award, but it's the first ever given to any kind of a government agency. And it was given to the Division of Corrections for the work that they've kindly allowed us to participate in for the last 5 years in terms of reforming, or as the Secretary Greene calls, transforming a number of things in corrections, including rolling out a 40-hour staff training and something called the Crisis De-Escalation Team. And they have managed to train over 225 people so far, trainers, and they're rolling out regional trainings every month. So I don't want to take the air of that sale, but I wanted to say that we gave the award, and it shows a great, I think it shows great leadership that we had to bring 2 tables in, especially because Secretary Greene brought all of his leadership and the people who were delivering the regional trainers and the head of training. So we had 12 representatives from the department to be there to accept the award. Without further ado, I'd like to introduce Secretary Greene. He was appointed Secretary of the Maryland Department of Public Safety and Correctional Services by Governor Larry Hogan in April 2019. He has more than 34 years of public safety experience, most recently as the director of the Montgomery County Department of Correction and Rehabilitation. During this time, he created a detention services reentry unit at the Montgomery County Correctional Facility, which was nationally recognized and replicated in other jurisdictions across the country. While under his watch, the department received numerous National Association of Counties awards for innovations and commitment to the best in correctional practices. Secretary Greene also served as the Director of Corrections and Corrections Bureau Chief for the Frederick County Sheriff's Office. He began his career in 1985 as a correctional officer following completion of the academy. This experience has given him a unique perspective and advantage in the care and custody of those incarcerated, as well as the men and women who serve and protect on a daily basis. There's more in the program. Please do read your program. Without further ado, Secretary Greene.
Thank you. Good morning. I hope you don't, can you hear me okay? I'm going to walk and talk because I hate standing behind those things. We'll do, I hopefully give you 15 minutes about who we are, what we do, and maybe a brief history of how far corrections has come with the help of NAMI and other organizations. First off, it is Fancy Sock Friday. Tradition in my household, so I get to wear my fancy socks on Friday. Who are we? As the Maryland Department of Public Safety and Correctional Services, when you think about the intersection of mental health and maintaining the lives of people in corrections, I will take for granted that we all understand and have read that many of our jails and prisons have become, not by my choice, the de facto mental health treatment facilities in the 90s, 2000, and moving forward. I'm pleased to tell you that in Maryland, we're doing well. We're trying to redefine our narrative. Last night was a part of redefining our narrative. We're often seen as, we're defined by entertainment media. We're defined by Netflix videos, Netflix about what we do and how we do it. It was very important last night for this group and you and those that were present to meet the people that do the work every day. As the Maryland Department of Public Safety and Correctional Services, we have really a broad spectrum and the opportunity to touch a lot of people. Through justice reinvestment, at one point in the state of Maryland, we were housing nearly 40,000 people in prisons and our jail systems. In Maryland, we have 21,000 under supervision, under my supervision today. Of those 21,000, 19,000 are being held in the Department of Corrections facilities, DOC facilities, across 23 facilities in the state of Maryland. We also have a unique relationship in the state of Maryland where Baltimore City Jail is also, the Baltimore City complex is managed by my office. We are one of 2 states in the United States that have not only a sentenced custody component, but also a pretrial component in Baltimore City. Thank you very much, because I was starting to go blind. I was seeing dots as I was looking at you. So that's a unique relationship, 19,000 in secure confinement. When you think about that number, opportunities for us to touch people, we're maintaining individuals in our Department of Corrections system that are serving a sentence of 18 months or longer. So in the state of Maryland, 18 months or less, you're going to stay in a local county jail, and that term of confinement, 18 months or longer, you're going to go to the State Department of Corrections. So in our system today, out of 21,000 people, we'll talk about pretrial in a moment, we have 5,000 plus individuals that have been diagnosed with mental illness. We have 1,700 plus that have been diagnosed with serious mental illness. Those are individuals, some of which 4,428 out of the total number returning back to the streets of our communities in the next 24 months, going back to the county that they perhaps came from, where their validated release plan is to go back and live, thrive, and be connected to services that they need there. We're also maintaining people that will spend the rest of their natural life inside our system. That is a reality. And how do we create an opportunity and the ability to manage that broad spectrum? It is a very unique body of work. When you add in the pretrial component, Baltimore City Jail, we're touching 21,000 individuals. We have central booking. Individuals come into central booking, booked into our system. We're touching everyone coming into the criminal justice system in the city. Again, 20,000. That's an opportunity, bless you, and everyone around you. That is an opportunity for us to make an intersection in people's lives. If they're not staying with us, how do we, when you think about reentry, reentry is not warm and fuzzy, it's essential. How do we take a person at the point that we first touch them and they're with us for an hour to 18 months or longer? How do we begin to make change, impact, and connection into a lot of the services that all of you are connected with or investing in? And we're investing taxpayers' dollars in. So from the mental health side of the house, we're operating multiple inpatient units across our system, serious mental illness units. At Patuxent, we're operating step-down units. We're looking at cognitive behavioral change therapy. We're looking at all of these different intersections that help us manage people. It is not an easy job. But the real important factors that I think I'd like to have a discussion with you on are not just the challenges, but those opportunities. So across the department of 10,600 plus employees, we've just recently increased our mental health service capacity from 102 staff to over 200. I have social workers in the room. We're recruiting. We're recruiting. This will be my gratuitous part of the recruitment part. If you've ever thought about a career where you would have the opportunity to work with the most dynamic and diverse group of individuals, you probably don't think much about corrections. We have a place for you. Whatever your interest is in reentry, connection to community, substance abuse treatment, social work. I'm married to a social work professor. So we created an internship program about 15 years ago into some of the jails and prison systems in the state of Maryland. We encompass all of those classifications. When people often see us portrayed on TV, it's the officer with the badge a little bit swelled up in the shirt that is a little too tight. That is not us. That's not who we are. We are officers. They provide the umbrella of safety and security that allows good programs to operate: social work, teachers, nurses, psychiatric nurses, case managers, reentry specialists in this system that is very broad. It's very much like managing a small city for me. So what does the future hold for us? The future holds, I think, just a number of incredible opportunities. Under the Hogan administration, we are in the process of planning, envisioning a therapeutic treatment center for Baltimore City, a 1,300-bed plus purpose-built, really important statement, purpose-built facility to deal with exactly what we're seeing. It is data-driven, it is research-validated, and headline-tested. We know what we need in the city to help people and transition them through the system. We need to be nimble. Purpose-built facilities are nimble. They are nimble in how do you move a person into detox, into recovery, into treatment, and don't create systems inside the walls that we can't find in our community, which means when we're visioning it and we're building it and we're designing it and we're putting it together, making sure that the stakeholders represented here have a voice in this process. I'll be running out your door at 9:30 to at 9:45 be in another meeting across town to meet with the designers and the individuals that are helping us vision such a facility. 2 weeks ago, Governor Hogan, you may have seen him on the news, taking down the old jail that was built prior to the Civil War, that was not purpose-built for the work that we need to do there. So it is an incredible opportunity to provide this opportunity, therapeutic treatment center, purpose-built in the city. I'm very proud of the work we do. Some of the guests here today got to meet our staff last night, the people that do the work. And we were long-winded, again, my apologies, but we lined up 12 people, and the pride they took in explaining what they did to help develop the crisis de-escalation team model. We've trained 247 people across our department. I'm really proud of that. Line correctional officers, yes, we'll take that. Line correctional officers inside facilities, case management staff, sometimes walking into the room a little bit, what is in this for me? And 40 hours later, when I've had the opportunity to attend the graduations, beginning, I think, in the ability to see themselves in their work and see a program that will transcend their work inside the prison, inside the walls, because then they begin to see the application in their personal life and their family life. And I am a true believer, everyone has a story. Everyone has a story that motivates them, that brings them to the table, feeds their soul, and we have provided our staff the opportunity for that. They're talking about, well, you know, I used it the other day with a guy that didn't want to take his medication, and I didn't need to call the nurse. I didn't need to call. I was able to, de-escalate, and in our environment, ladies and gentlemen, that can take hours. While our numbers have dropped to some of the previous highs that I talked about, incarcerated, 21,000, the acuity of the population, 45-degree angle. I mean, it is increasing. The amount of time we're spending with fewer people is incredible. So training our staff, our officers, everyone inside the walls to deal with those special needs, special circumstances of individuals that are experiencing mental illness and in crisis is a real important part of our work. I'm really super proud of it. And if I would tell you, your correctional system, if you're from the state of Maryland, when I came here, one of the things that I've found has been most humbling in my 160 days is the depth and breadth of knowledge of the people, their humility, and how much they care about the work that they do. You will read from time to time in my system, in any correctional system across this country, things happen. Violence occurs. And we read those pieces, wish they didn't happen. But we also want to tell the rest of our story. Our narrative is not just that. If you have a desire to come and see our facilities, we are very transparent. Through organizations like NAMI, you want to put a tour group together and come and see, happy to do that. We're doing that all the time. These are your correctional systems. You are welcome to understand how we work, what we do. We put a lot of information in the field. We're designing data dashboards now. I'm very much data informed, not just driven, but informed. There are some things that we do that are just the right thing to do. But being data informed in who we have, what we're doing, what are our successes and what are our challenges, but dashboards that don't tell us that once a year, that don't tell us that once a month, that give us an immediate snapshot out of our systems of how we're doing our work. So I wanted to give you an overview. I wanted to thank you for being here and your interest in this work. I believe that correctional systems and community health systems were this. And if I'm doing my job right, we mirror each other. And we need to make sure that people are going home connected to many of the things that each of you have established in your communities. That's kind of my overview. How much time do I have left? Because she knows I can talk forever. 5 minutes. Questions. Things that you always wanted to ask someone that's worked in jail or prison for 35 years. This is your time. Be happy to answer them. Yes, ma'am. Which facility? The Therapeutic Treatment Center. It's right downtown. It's downtown on the site of the old jail, if you've in downtown Baltimore, between Madison and Monroe. We are on that site with some of our training facilities. No, ma'am, this is downtown, right in the center of Baltimore where it needs to be, where individuals are coming into booking, and we can look at the kind of the three-door model. Deflection. Deflection's not bringing them into the system to begin with. We can look at diversion. And then when someone has to come into our system, how do we, in a very nimble fashion, get them into treatment, get them into programs? It's going to be placed exactly where it needs to be. All right, yes, I'll just kind of come up this section. Are you working with the juvenile justice system as well? Juvenile justice in the state of Maryland is a total separate entity. Again, under Governor Hogan's administration, we opened up the youth detention facility 2-3 years ago, housing individuals from 14 who have not yet reached their 18th birthday, but the juvenile justice system is separate. Let me get another one in the center section. Yes, ma'am. Yeah, we're connecting with local health department, connecting with the state health department, connecting with service providers. We need to do, I won't say a better job, we need to transform that process a bit more. I have no desire to start a program in my facilities that I cannot find setting in this room. We do not need to create the same folks, or different programs. Let me give you an example. We talked last night, I was talking about social workers when I hired my first 2 social workers in Frederick County, Maryland. I'd fought very hard to get 2 social workers coming into the facility. Once I hired them, I said, now, talk to the boss, not my wife, the sheriff. And I said, I want these folks to work 20 hours in the community, 20 hours in the jail. What are you doing? This was in the 80s, 90s. Early 90s, begins to fade together. And what are you doing? Why are you giving up our hours? You will see. So we're setting in mental health management and community health management meetings. Johnny has done very well. We haven't seen him in a year. It's because he's in jail. Oh, okay, well, let's make that connection. Jenny's been doing wonderfully. We've released her. Jenny's in my system, and she was stable for 30 days. So we created, I tell you that to tell you this, we created that connection, and it was a life learning lesson for me in the profession that the connection has to be the same people, the same program, the same services, because when we make a human connection with each other, we're much more likely to follow through. rather than having two programs, two different people, two different intake processes. My desire is to bring more of that which is customary, already existing in our communities, whether it be Baltimore City, whether it be in Hagerstown at our pre-release center there, or it be on the Eastern Shore at one of our facilities. What is normal and customary to that individual going back into that community? It's creating strong connections to every county across the state that has unique relationships, opportunities, and services because people are coming home. We'll come over here. Yes, sir.
Well, thank you for your passion and your insights and your enlightenment. First of all, thank you very much.
You're welcome.
Yeah. Where are we at in Maryland with solitary confinement and other types of less humane approaches?
All right, so we talk about restrictive housing and we talk about solitary confinement. When I hear the word solitary confinement, I don't believe I have solitary confinement anywhere in my system. It doesn't exist. Solitary confinement, where an individual is in a cell and they're not seeing anybody, no one's coming by to check on them, and there's this total isolation with no human interaction, I don't believe I have that anywhere in my system. There is a place in what we do for restrictive housing. You'll use the word inhumane and at times very necessary. And how do you preserve an individual? How do you provide a safe environment? And in some cases, restrictive housing is applied to an individual that chooses to be in that environment. It's not the housing arrangement only, sir. It's the services that you have coming to them every day, trying to make sure, from a case management standpoint, psychiatric services every day. There's a body of national standards that I actually sat on the committee that helped to write those. It took us 4.5 years through the American Correctional Association looking at the body of work of restrictive housing. I want every person, and I will demand that every person be treated with dignity and respect, but there is a place in our systems for it's a necessary place for restrictive housing done appropriately. I can probably do one more, and they're going to put the hook on me. Yes, ma'am. You just looked anxious. Hello. Well, I think we often talk culturally, and we throw in the word cultural diversity. This is far beyond that. We have to be competent. Cultural competency in the work that we're doing and the reality of who we have in front of us. I think it's represented in the employees that we hire, the organizations that we associate ourselves with, and there's a body of research that comes out of many of the programs that we work with that talk about fidelity of the program, cultural competency of the program. We can't, and again, I'm not creating correctional programs. I'm taking service, licensed clinical treatment. I don't want drive-by. I want licensed clinical treatment that is acceptable in our communities. That's what I want coming into our system. And I think when you do it that way, you get that cultural competency, you get licensed clinical treatment, you get fidelity to the processes that we've built. Hopefully that answers your question. All right, very nice. Thank you very much for your time. Look forward to it again.
Send any questions, and we'll get them to Secretary Green. Glasses? Somebody's glasses? Glasses? Secretary Green? Yes, they are. So I need a little money. What could I have gotten for those? No, I just wanted to mention that there have been a number of changes relating, I mean, this new detention, the new center is going to make a big difference, I think, in a lot of, including in the issue of, Sharita, in the issue of disparities. Because if you are deflecting people, if you are diverting people, and then you're also getting them care, making sure that they're connected, hopefully with services in the community, which we all need to advocate for, it will help, but it's a big issue. But there have been a number of changes over the last 5 years, including not just in terms of training, which is making a big difference in the number of, but also procedures around such things as, there is such a thing as good restrictive housing where people actually get the care they need. But there's also been, Maryland had a horrible reputation, actually worse than, Mississippi, in terms of the use of what's called administrative segregation, which was basically punishment for inappropriate behavior, which got somebody into basically punishment cells. For prolonged periods of time. So procedures have been adjusted, and there's a lot less of that. We're watching the data. I'm very privileged to be the only civilian on a steering committee in corrections, and I'm seeing the data. I'm not allowed to release it. I think the department might release it soon because I think the new secretary believes that it will be important for people to see. But there's a lot of changes that are happening. There's a lot of work to do. And advocates can certainly, and all the community can really help. So take the secretary up on his offer, especially Baltimore, seeing the new center. And any questions from anyone who's at an affiliate level, we're working directly with corrections all across the state. We're part of the training, and we are going to be coming to you and asking for some people to train to help us with that. Moving on, I apologize, but Melissa Reuland generously gave up 25 minutes of her time so that Secretary Green, yes, Secretary Green could speak. But Melissa Reuland we've known her for years. I think I met you at the very first training in Maryland of police officers in Baltimore County. And she's got long credentials. But I'll just say very quickly that she's a senior advisor to the Bureau of Justice Assistance, funded Vera Institute of Justice, Serving Safely initiative. And she is one of, if not the national expert on what it takes to have effective police response to mental illness. So those of you who are here, all of you, are members of local communities. You need to know what are the core essential elements of effective police response. It's not just training. And so without further ado, Melissa's going to get up here and tell you what you need to know.
I'm shorter than Kate. I'm shorter than most people. It's why I don't mind being up on a podium, to be perfectly honest. So good morning, everyone. I really appreciate coming to this conference and being a part of my local community's efforts. I spend a lot more of my time running around the country than I do running around Maryland, so I'm always very happy to be here. So I am working with the Vera Institute of Justice now. The Vera Institute is housed in New York City. It's a policy and advocacy organization that has worked at the intersection of criminal justice and equity, and racial equity and justice for more than 35 years. So I was very glad to be joining Vera, and I do get to go to New York sometimes, which is my hometown, which is always fun. And I have seen, in the last 25 years working in this area, a tremendous amount of change. I think the Secretary Green is one astounding example of the type of change that communities are now engaged in addressing what it means to have a safe encounter with someone who has mental illness, both in law enforcement and in jails. And usually when we do these presentations, police sort of comes first, right? Because police are the first intersection of people who are in crisis, who may come into contact with law enforcement, and it's their efforts and what they do in those encounters really matters tremendously in keeping people out of jail in the first place and getting them connected to services in the second place. So what's the problem? I'm very problem-oriented. I got into this business in policing in the late 90s, and it was all about problem-oriented policing. It's really kind of how I was raised in policing research. So how about this? Officers complain that taking someone to the psychiatric service of the hospital is tedious, cumbersome, and uncertain procedure. They must often wait a long time and are occasionally obliged to answer questions that appear to place their own judgments in doubt. This is from Aegon Bittner. Aegon Bittner was one of the seminal police researchers in this country, and this quote comes from 1967. So we've been dealing with these issues. When we talk about police making a choice or having to make a decision about where to take someone, to jail or to the hospital, when this was the situation at the hospital, the jail was much easier, right? I think for a long time, police officers thought jail was safer for people. They thought people might do better in jail. If they took them to the psychiatric facility, they would be out in a couple of hours. These things are still true. So today, we know that law enforcement officers lack information and skills to de-escalate crisis. In the last year and a half, I was working on a Serving Safely initiative. It was funded by the Bureau of Justice Assistance, which has generously funded reform efforts in this area for as long as I've been working in policing, for 25 years. And we got calls from all over the country of agencies looking for assistance on responding to people with mental illnesses. And I was shocked, I tell you, to find out how few communities knew about these models and knew about what they entail. So continually, we know that officers lack this information. We also know they lack reliable and efficient access to mental health and behavioral health services. This is an ongoing battle. I think we may be starting to see a little bit of a tipping point, a little bit of a turning of the tide in terms of where do we direct our dollars, direct them into the community for community-based mental health and behavioral health treatment. We know that calls for people involving people with mental illnesses are complex, time-consuming, and potentially dangerous. I'm not going to say the word dangerous a lot more in this presentation, but I do want to say, from the policing perspective, when people call law enforcement to come to their home, it's because they have used up all of their other options. And it's oftentimes because they think the person is dangerous, to self, mostly, and sometimes to others. So when law enforcement go to these calls, what's their job, right? One of their jobs is to determine whether the person meets criteria for emergency custody. They are solely have the opportunity to take people into emergency custody against their will. And because of that power, we've created a lot of rules around that. But they're there to determine whether someone is dangerous. So when we think that officers think that people with mental illness are dangerous, it's because that's what they're there to do, is to determine that feature, and they only see a very small percentage of the population with mental illness. So I'm not going to get into a debate about this. I just offer that as a perspective for us to keep in mind as we talk about how to help law enforcement respond better. Because of these circumstances, we know that the largest inpatient mental health facilities in the United States are actually jails. Los Angeles County Jail, Chicago's Cook County Jail, and New York Rikers Island, which I saw a headline today that they've made the determination to close Rikers Island by 2026 and replace it with 4 smaller jails in New York City. They each hold more inmates with mental illness than any psychiatric hospitals in the United States. So the solution: never doubt that a small group of thoughtful, committed citizens can change the world. In fact, it's the only thing that ever has. I believe that these programs that we talk about today are programs that are based on the work of a small group of committed citizens like yourselves. This is not rocket science. It is, however, time-consuming and takes a tremendous amount of dedication. So police mental health collaboration. This is my very busy slide. I want to enforce that police mental health collaborations, we call them PMHCs, right? This is an umbrella term that encompasses a number of different program types. Many of you will have heard about crisis intervention teams. That's one type of a police mental health collaboration. We estimate there are more than 2,000 of these programs worldwide and counting. But there are 18,000 police departments in this country. We have a long way to go. Some of those police departments, I learned this year, have never heard of crisis intervention teams. So we are still working at the Vera Institute of Justice to maintain our Serving Safely program and continue to respond and help communities become aware of these programs and implement them, which is very complicated. So crisis intervention teams, self-selected cadre of officers trained to identify signs and symptoms of mental illness, de-escalate the crisis, and bring the person to a round-the-clock efficient treatment center. Has anyone ever seen that actually happen? Yes, because it used to be that this is the ideal, right? This is what we're aiming for. And communities are doing parts of this, many of them. The 2,000 we know about are probably doing 2/3 or 3/4 of the work that's needed to get this to happen. But this is a process, right? This is iterative. We have to do the parts we can do now and continue to work to fill in the rest. Co-responder teams emerging have been actually going on in the same time period span that crisis intervention teams have been in action. They have just started in California and in Canada, actually, because there was a different problem to respond to. Co-responder teams involve a specially trained officer who's paired with a mental health professional to respond to the scene of a crisis involving mental illness. The mental health professionals work with officers both in the cars, they respond to the scenes, they respond secondarily after the crisis has been sort of settled down. They co-respond after the person has been released days or weeks later to try to connect that person to services. There are also follow-up case management teams. This is when we have specially trained officers work closely with mental health to identify people who repeatedly come into contact with police, and they work in the collaborative group to develop customized solutions. I knew a detective in California that had worked with mental health and is one of these case management teams in Los Angeles, and she would call the person first thing when she got in the office to say, have you taken your medication today? Hi, it's Detective Rodriguez, have you taken your medication today? Person would say, oh, let me go get my pills, detective. Take the medicine, and then all was well. This person had been calling the police, hundreds of times in the past year. So these are the type of customized solutions you just don't necessarily see everywhere, but those situations involved a specialized response. There are add description, I never fixed my slide. Mobile crisis teams, you guys know what mobile crisis teams are. They respond, so we have sort of an emerging mobile crisis teams. There's one in Eugene, Oregon called Cahoots, which I just love. And what they do is they work with law enforcement, but they don't have a law enforcement officer on their team. Instead, they have a community paramedic. So they have mental health service expert, they have community paramedic, and they follow up. It's sort of like, they also will come to the scene if police call them. So it's sort of a really interesting kind of mobile crisis team. And then we have multi-layered responses. Many communities have CIT and co-responder, or they have co-responder and a follow-up case management team. And in very large cities like Houston and Los Angeles, they have all three. And one of the key words on this page is tailored all the way at the bottom, because if people are implementing a crisis intervention team, but they don't really have that problem, and I'll say more about that, they may not see the results that they're looking for. So what are the advantages of these programs? We see increased connections to mental health resources. We see reduced repeat encounters with law enforcement. We see less arrest, and we see reduced use of force with people who have mental illnesses in those encounters. So these are the goals of many of these programs, and they are achieving these goals. Some of the research we have is descriptive. We don't have randomized controlled trials in police mental health collaboration programs. And frankly, we could argue about whether we need them. I think that the community-based experiences, and part of the issue is a lot of communities have great data and it's just not out there. So we're encouraging BJA to work on that. But there is a lot of really great data out there that these things work. So the framework that we're talking about It began with 10 essential elements that we developed based on recommendations of a broad range of practitioners more than 10 years ago. We have a new resource that's available. It's called the Police Mental Health Collaboration Framework for implementing effective law enforcement responses for people who have mental health needs. Not sure they could have had that a longer title than that. It's developed by the Council of State Governments. I worked for the Council of State Governments through most of the mid-aughts. So I'm very proud that they've released this. It's a guide mostly for executives and communities to sort of look through their community to see what is it that we need to do next. They provide a common framework for program design and implementation to promote positive outcomes. We know that if you're doing pieces of a program, you're not as likely to have the best outcomes as if you were in, except when you, anyway, you need to do all the program elements, right? That's how you get an effective response. So people need to know what those elements are, and these documents provide that guidance. And these are sensitive to jurisdictional needs and resources. We can't, this is not plug and play. We can't take a program and say, do all of this, because it won't work in every program. Crisis intervention teams were developed in Memphis in the mid-1980s, and Memphis is a certain type size city with a certain type of leadership perspective, with a certain types of resources. Other communities may not have those resources, so these elements in this framework is designed to help all communities address these issues comprehensively. And we need to collect data and use it to inform policy and practice. If we're not collecting data on what we do, we don't know if it's working. And once we know it's working, we can get people, government, see the specter, right, of Secretary Green here, to get these, to do this work, right? So the 10 essential elements help. They provide this framework, they're sensitive, and they reflect a process-oriented approach, right? Not plug and play. So we talk about how to develop these programs, not only what they are. See, the essential elements, the first 5, it's sort of in time sequence, right? So the first element is collaborative planning and implementation. We need to have a collaborative group come together, all stakeholders at the table. Everybody has a voice. People who are there have decision-making authority. If the police department doesn't send someone who has decision-making authority, you're in trouble. That's captain or above, okay? And the rest of the community needs to send people with decision-making authority also, include mental health professionals, public health, until the people who are at the table can make decisions. The collaborative group kind of floats around. I've seen that there's a huge collaborative group in Baltimore City with like 200 people. I'm like, how is that getting anything done, you know? So there are a lot of reasons to be very careful about who goes on this group and the structure of the group, because this group is going to be essential in doing the second and third elements. First, they need to design their program. It's not just CIT all the time. It's CIT and or co-responder teams. It's what is the problem in my community? How do I decide what to do next? And I'm going to talk a little bit more about program design if I have time. Specialized training is critical to these programs. We need to get officers to understand how to de-escalate, not just what de-escalation means, but to practice it. The crisis intervention team training, the 40-hour training, is transformative because law enforcement officers practice what they've learned. They don't just hear about it in a classroom, they practice it with each other until they develop some competency in those skills. And the training, the reason you have to design your program before the training is what they need to be trained on the program that you have in place, right? So putting in training without designing your program, without doing policies and practices, is ultimately going to cause problems in the way law enforcement officers respond. It is a paramilitary organization. There are lots of rules, there are lots of practices, lots of policies. And if you have it in policy, they can be accountable to it, right? So we encourage agencies to develop policies as well as develop programs. Next, the call taker and dispatcher protocols. This is an issue that's become a little bit more in the forefront in the last 5 or 10 years. Dispatchers really are the gatekeeper in many ways, not necessarily law enforcement. So dispatchers are the ones that find out, well, call takers. So in some communities, and this is true in Baltimore City and Baltimore County, you have 2 people. You have a call taker who takes the call, sends, and decides to send it to dispatch or not. That call taker is very important. Not all calls require a dispatch. And some communities are now developing a way for some calls to go to a mental health professional who's actually sitting in the dispatch center. And the call taker stays on the call, the mental health professional takes over, and they determine together whether a law enforcement officer needs to respond. Because wouldn't it be great if we could keep everybody safe and keep people out of the jail by not even having an officer attend the call if that's not necessary? So I think partly we're really moving in a direction now in this field to reduce the amount of law enforcement time in these encounters, and this is one way to do it. And also training dispatchers. What information do officers need or not need? The situation that happened in Fort Worth, Texas, it sounds like there was a lot of miscommunication. I do not accept that that person's behavior was in any way appropriate to kill somebody through their, I mean, this is a terrible tragedy. How do we prevent something like this? Partly it's how much information dispatchers provide to law enforcement. And they were not getting training, and they were not getting into this picture. So now we're really getting there, which is excellent. Element 5 is stabilization, observation, and disposition. That's work the officer does on the scene. They need to stabilize the scene, observe whether there are signs and symptoms related to mental illness. They need to determine whether the behavior they're seeing that resulted in the call is actually a behavior related to mental illness and not a criminal behavior. And then they choose the proper disposition. Should the person go to jail, or rather, should the person be brought to a mental health resource? And there was a recent, the findings from the recent behavioral health, so the consent decree required in Baltimore City required a gap analysis in the city for mental health services, and they just released their report. And there's a very small section on that report. What was the organization? Behavioral health? Who wrote that report? Have you seen it? I've seen it. Yeah, okay. Anyway, so it's a city agency. But they looked at the police calls, and they found that in the one area that they had data, it's not very reliable, but in fact, the police in Baltimore City in this one sector arrested very few people, like 4. But 700 of them were brought to the University of Maryland in emergency custody for a psychiatric evaluation. Now, the University of Maryland Emergency Department is not set up to do 697 emergency evaluations in a 6-month period. So when we talk about disposition, now we're starting to talk about not just diversion from jail, but diversion from the emergency department. Because what happens is people get turned over and brought back into the community within a couple of hours, right? And that's not helping any either. So although we've made a really great shift from arresting people to bringing them to emergency departments are not the answer. So the discussion in this document that's looking at the gaps and is making recommendations to the consent decree monitors is that there obviously needs to be another community-based resource for people who are in need of emergency services. There are a lot of models out there for how to do this. One of them is in Tucson, Arizona. Dr. Margie Balfour has worked very hard to develop a crisis response center that officers can bring people, and there's a no refusal policy. Officers can bring anyone, including people who may be dangerous or have aggressive behavior, and these folks are monitored by psychiatric staff 24/7 for several weeks if necessary. It is there's an amazing opportunity in the city and the county now to develop these resources, not just as a diversion or deflection from jail at the point of jail, but prior to jail. So I think I have hope that the consent decree will help invigorate discussions around that as well. The last 5 elements sort of occur, some of them are a little minor, like transportation and custodial transfer is something that is very important to some communities about how do we handle handcuffing, how do we treat people with dignity and respect who are being brought to jail, and when we transfer their custody, what information transfers with them? Because people who receive these individuals need to know what kind of medication they're taking, what kind of strategies have worked for that individual. Information exchange and confidentiality is obviously a talk all in and of itself, but it is an issue that needs to be dealt with. Treatment supports and services, as I said, another huge issue. If we could train all the law enforcement officers we want to, but if they don't have somewhere to take the person that's an effective treatment facility, we're not going to meet our goals. Organizational support is critical. oftentimes in police organizations, law enforcement officers are given credits, right, every time they arrest someone. And when they're looked at, their performance evaluation is looked at later. It's how many arrests did you make, how many good arrests did you make. Now, if we're trying to divert people from jail, we need to start rating officers on a different scale altogether, right? We need to add those types of things so that they're getting kudos and reinforcements for that kind of work. That takes organizational support. And program sustainability and evaluation is critical to sustainability. If we're, officers, police departments have, over the last year or so, I've talked with many, have said, well, how much does it cost to do these programs? And if I was, some police chiefs that I've talked with have said, well, how much does it cost not to? And that's kind of the message, right? It's a terrible message, right? It's saying it costs a lot, right? If your officer kills someone who has mental illness, that can cost your department millions and millions of dollars. I hate this argument, but it's an effective argument. And we need to start getting agencies on board. And so cost should not be an issue. But if you're going to sustain there are costs. If you want to sustain a program, you need to show that it works at saving those other types of costs. So program design, let me talk just for a few minutes about this. This is your collaborative group that designs your program to address the causes of the problems that are impeding the improved response, right? So we can say, and many people, including my family members, say, these officers just suck, right? They're just terrible people. And they really are nasty, and they're racist, and, they just need to be fired. And I think, well, while all of that is true, right? It's true, but it's not really the main reason why poor response to people with mental illness is on a broad scale, right? If we look broadly at behavior, it's because they don't have information and they lack access to resources, and they don't have skills. And I'll just take a minute to say this because I think it's important. When law enforcement officers are trained to respond to a call, right? Let's say I call an officer and I heard a noise in my backyard, right? Because I'm worried that there's somebody in my backyard. Police officer responds, he says, ma'am, what's the problem? I say, I heard someone in my backyard. I'm not sure what it is, but I'm scared. This actually happened. And he says, all right, well, you know what? It looks kind of dark back there. I'm sorry, I'm just not gonna, I'm not gonna go. I don't think it's safe. You know what? It's not that big a problem. I'll see ya, right? That's not what law enforcement officers do. They do something. They're trained to do something. They're trained to get out the mag light, and they go in the backyard, and they look around, and they say, ma'am, everything's fine. There's no one in the backyard. So if we're going to reform this whole process, we need to give police officers something else to do. And when they're trained to go into the situation, they're trained to go in and establish authority and take control. And they do that with the way they stand. I mean, you see this, the way their uniform, the presence of their gun, all of this is to gain control of the situation. All of that is very bad for someone who's in crisis. So what this training does is help officers shift, right? Not all officers can do this, but officers to shift and say, oh, this is not a situation where I should be establishing my control and authority. This is a situation where I take a step back, I loosen my shoulders, I say, hey, what's going on today? It sounds like you're having a rough day. Can you tell me what's going on? Can you tell me why you're upset today? It's completely different. And they need to learn how to do that. And they need to have permission to do that. That's the policies and procedures side. The training is how they learn. The organizational support is how they continue to do this. Here, their officers being lauded for de-escalating crisis, okay? So that's fundamental to these programs, is that understanding of the shift, right, in the officer's perspective, okay? So that's some of the cause of these problems, right, is the way officers are trained to interact with people. There are all kinds of other problems, right? We don't have community-based services and supports for folks. So let me go on. So the program design hinges on effective collaboration. Everybody needs to be at the table to understand what the problem is, right? You identify those problems and their causes, right? So again, if officers are going into situations with all this kind of authority, We need to change that. That's kind of one of the problems, things we need to change. We change that with crisis intervention team training because people are dying. And crisis intervention team training is designed to help officers not kill people, okay? Essentially, that's what it's designed to do. There are other problems in the community. Lots of communities, I mean, according to the Washington Post, 1,000 people die at the hands of law enforcement every year. This has been a stable trend. Since they've been doing it, it's like 3 or 4 years now, WAPO's been collecting these data. A quarter of the people they identify, bless you, and everyone around you. I love that, and I'm saying that all the time. Those folks had mental illness, right? So 250 people a year are dying at the hands of law enforcement who have mental illnesses, according to the Washington Post. And I might not be popular for saying this, but that's not very many people. We're talking about millions of calls for service every year. And I need to get that slide, because somebody had a great slide on this at a recent training. If we look at if that was an injury rate for, bless you, a medical procedure, I don't know that anybody would be terribly concerned, okay? I like to bring out the medical model because people are dying at the hands of doctors all the time, just saying, okay. So one of the problems that we see often is lack of available community resources. And the co-responder teams, those teams address that problem. So you need to know the problem, design the program, and tailor what you have and what you do to your system characteristics. 1 second, collaboration, collaboration, collaboration. If you guys are not at the table, it's not going to be as good. And sometimes it means inviting yourself to the table. I don't doubt that anybody in this room can do that, but you might have to encourage your colleagues and your friends to be strong and do that. We need to use data. Tailor the program activities to the problems in your community. Look at the process and the impacts. And you need to be creative and adapt to your environment and iterate, iterate, iterate. It is not about doing it exactly the way Memphis did it. It's about doing it comprehensively, things that meet your community's needs. If you want to reach me, I have my card. I'm available all the time. Happy to reach, happy to talk. Here's my 2 emails, and thank you very much for your attention. This is my friend.
I just wanted to mention that the 10 essential elements that Maryland Behavioral Health Coalition adopted, those 10 essential elements, and massaged them, added a little bit, yes.
Customize them.
Customized them as part of the model. But they are available, I believe I'm sure they're on our website. But if anybody wants them, just when you go to the sign-up sheet on just say that that's what you'd like to have emailed to you, but otherwise it should be on our website.
One quick question?
Yes.
Okay. I think with an increasing awareness, as officers become aware of trauma-informed care, as they become trained, it has become clear to them that these experiences are in fact traumatic. And there's work being done. It's not my work. I can direct you, but there's been an increase in programs that help officers address their own crisis. In fact, when you have a mental health crisis person, like a mental health professional who's working on a co-responder team with law enforcement, many times that professional becomes a resource for officers as they deal with their own crisis and trauma issues. In fact, I was just in a community in Jacksonville, North Carolina, where that particular person said that she sees 4 or 5 officers a day that come to her and close her door. And she has her office set up so that you can't see in. Like she put a thing over the window so that they can be, yeah. So no, I completely understand your perspective, and I think it's really important for them to care for themselves so they can respond to us effectively.
I also wanted to add that most, any good 40-hour training, and those of you who are advocating at the local level, any good CDT, CIT, 40-hour training and refreshers should include self-care, and there is almost always, as Secretary Green was saying last night, and many of the people who were standing up there who were trainers were saying that the training itself was transformative for them also, because they were recognizing things that they needed to do, not just for themselves, but also to help fellow officers. So there was I think it's a really important point. I'm sorry we don't have any more time. But
I'll wait around for a little while.
okay, and we will be going, you have 10 minutes. Thank you very much, Melissa.